Apologies for the late start. Good morning, and thank you for joining us for the 2022 World AIDS Day report launch and panel discussion for the Asia-Pacific region. My name is Cedrian Martin. I'm the Communications and Advocacy Advisor for the Regional Support Team here in Bangkok. We're so pleased that you could join us for this World AIDS Day commemoration. This is a day on which we reflect about people whose lives have been lost due to the AIDS epidemic. But in 2022, World AIDS Day is also an occasion of hope. We have the tools and we have the knowledge to end this epidemic. And so we use the opportunity of this commemoration to reflect on what's going well, what we need to do more of, but also what are the challenges, what are the gaps, what do we need to stop doing, and what do we need to scale up. We're going to have an esteemed panel join us today to reflect on the experiences of Asia Pacific, reflect on the way forward, and how we could accelerate progress toward the end of AIDS by 2030. We start, however, with our Regional Director, Taufik Bakali, who will present for us some Asia Pacific data and findings from the new UNAIDS report, Dangerous Inequalities. So now I hand over to Taufik.
Thank you so much, Cedrian. And good morning, everyone. Good morning, colleagues. Thank you all for joining us online and offline here in the venue for this event to commemorate World AIDS Day and launch the recently launched Global AIDS Report, World AIDS Day report called Dangerous Inequalities. This report has been launched late last night, our time, and I'm very pleased to make an introduction of its contents and speak of its main themes and conclusions as presented, along with an update on the most recent data and evidence in our region. World AIDS Day theme this year is on the theme EQUALIZE. And this is really important. It builds on the Global AIDS Report, which was launched earlier this year, called In Danger. This report puts more focus on the inequalities that are affecting our progress to the targets of the HIV response globally, but also in this region. Inequalities are threatening response, are threatening the achievement towards ending AIDS, are even causing resurgence of epidemics in a number of places among populations and in specific geographies. And it's worth analyzing some of these forms of inequalities. This report specifically highlights different considerations of inequalities that are based on gender, that are specifically affecting key populations, and children. We will use the opportunity of this launch to speak a little bit more with some evidence on what is happening, or what some evidence that is shown up. But let's get back to an update on the main data that we have. Globally, there are about 38.4 million people living with HIV, of which 6 million are in Asia and the Pacific. And you can see the details by age and by gender: 2.2 million women living with HIV and 130,000 children with age less than 15. We still have about 260,000 infections per year, which is extremely high and way far from our targets that were set for 2025 and 2030 for ending AIDS, with notably about 14,000 infections specifically among children, most of which are due to mother-to-child transmission. Sadly, 140,000 lost lives this year due to HIV, and of which an unacceptable number of 7,400 children who lost lives to HIV, when we have all the technologies and the capabilities and the knowledge to save those lives and save those infections. 4 million are on treatment out of the 6. We are just about 2/3, but I am sure with the capacities in this region, we can do a lot more. So in short, as we were talking about treatment, this is the status of what we call the treatment cascade. About 76% of all our people living with HIV know their status, but I personally would like to see it from the number of 1.1 million people living with HIV do not know their status and remain at risk of transmitting the infections onward. Only about 2/3, as we have seen, of the people living with HIV are on treatment. And again, I see it from the other perspective. 1.4 million people living with HIV are not on treatment and risk to lose their lives. And 60% of people living with HIV who are on treatment have viral load suppression. We do not see, thankfully, from those numbers, a big difference in our region when we disaggregate by gender, male and female. A slight difference there, particularly for men being left behind, and we will see more in detail the reasons behind that number. But this overall achievement hides so many inequalities in between countries. As you can see, we have countries who are getting very close to achieving the 95 treatment coverage. Countries like New Zealand, Cambodia, and Thailand with very high treatment coverage, which is commendable. But still, a number of countries remain with an extremely low treatment coverage. At levels of 10 and 14 and 28%, as you can see from this slide. These major inequalities reflect also inequalities on capabilities of systems, on political commitment, but also effectiveness of service delivery models. We have major gaps to cover, particularly when you consider sizable epidemics. Are the ones who have relatively low treatment coverage. But let us analyze a little bit more in detail. When we look at the gap, sometimes we assume that it's because it's difficult in some contexts to find people living with HIV, which is true. But the reality coming up from this slide is that even you can look at the right side of the slides, those countries are the same ones who have very low treatment coverage. And this slide tells us that we have a very high number of people who know their status and are not linked up to treatment, which is a major loss for the efforts made for HIV testing, bringing the inefficiencies of the system, but also an additional number of inequalities and inequities that are affecting people even when they know that they are living with HIV and they're risking for their lives, they have not access to the treatment. There are various reasons for that. And we have the evidence that tells us about the levels of stigma discrimination, the inefficiency in system linkages between testing facilities and treatment facilities, and so many other issues, including gender-related issues and age barriers and policies and legal aspects that need to be addressed. But this definitely is a key element that we need to look at and address in our region, when not only we need to scale up the effort for finding people living with HIV through effective testing models, but also in ensuring that those who know their status are linked up to treatment to save their lives and prevent the onward transmission. Again, when we look at the trends of reduction of new HIV infections, we see the same level of differences in between countries, with some countries achieving as high as almost 90% reduction of new infections, which is commendable, showing a lot of excellent results, as we can see. But I always like to look at where the epidemic is increasing. When we have Philippines, a 327% increase since 2010 levels. Fiji, now the infections, that's quite recent, has been consistent, but considering Fiji is relatively a low level, still small epidemic, but that increase is very visible and worrying to us. Afghanistan, Timor-Leste, Papua New Guinea, and also Malaysia, which has been a successful story in the past in reducing the infections. And now we see the resurgence. And that resurgence of infections in a country like Malaysia give us a big lesson to consider in this region, that the HIV response, that the epidemic is not over, regardless of how much achievement you do, as long as you have inequalities. Those inequalities would threaten of bringing back the infections through some specific populations, as we can see from the following slides that are coming up. Again, this is the characteristic of our epidemic in the AP region. About 72% of all the infections are happening among key populations of men having sex with men, female sex workers, people who inject drugs, and transgender, particularly transgender women. And then when we add their partners, their intimate partners, wives and husbands and all these things, we come up to a 96% of all the infections closely linked to infections among key populations and their partners, which is a major characteristic to consider as we are designing our response and aiming to have an effective set of interventions. You can see here the disaggregation by different characteristics. Gender, 69% of the infections are among male, and that's specifically linked to the nature of concentrated epidemics where you have the clients, you have the men who have sex with men, and injecting drug users. Some of those key populations primarily and naturally male. And that reflects on the gender breakup of the number of new infections. But also very interesting to look at the age consideration. And I would like to attract, we have been looking very closely at this share of infections among young key populations, particularly, or young people, of 26%. And the important value for us is that 26% of the infections among young people is affecting among an age category that represents about 20% or even less than 20% of the overall population in our region. I'm very pleased to have Ika from Youth Lead joining us again for this event where we have been focusing on dissecting the disproportionate risk that is affecting young people in this region. 26% is not big, but it is higher than the share of that population in our region, and it deserves some serious attention. So let's start looking at some of the aspects that represent the inequalities that we see, and that's particularly, we start with the aspects of gender-based inequalities and how they do affect and hold back the end of AIDS and the effectiveness of the response. We have the data, and that's quite recent, 2020, 21, 22, even this year updates with regard to intimate partners violence. And let's remember that this is a key element of the global AIDS strategy. The 10-10-10 enablers targets specifically focus on ending gender-based violence. But you can see how high is the gender-based violence, in our region, both historically, experienced over a lifetime, or even when we look at it over the past 12 months, it's extremely high. And you could include maybe considerations related to COVID, lockdowns and all challenges, but there are aspects, because this data we have been seeing for quite long, even before COVID. The issue of intimate partner violence is really important because we know it has relations and links to preventing particularly women access to health. And this slide shows that even when the women experience intimate partners violence, they very rarely they do access health services as a follow-up. Now we talk specifically about intimate partner violence in its forms, in its various forms, but we know that there are other aspects of gender-based inequalities, including social norms that are preventing women from being able to decide on their own health or in accessing health service, including for pregnancy, mother and child health, and sexual health, and so on. And we have various data that is available from various studies, and this is really important to consider that as long as women and particularly with young women and young boys are not allowed to access facilities and decide on their own health, these inequalities will continue to hamper any progress towards ending AIDS, but also in improving the overall indicators on overall health indicators, including STIs, including maternal mortality, family planning, and so on. And these are interlinked elements that need to be considered accordingly. Let's look now specifically about key populations, and this is very pertinent for us in this region because of the characteristics of our epidemic as we have just presented in our region. Next slide, please. Okay, so we do look at data from a number of countries where we see that there is always some parts of the key populations or some key populations always left behind. Regardless of the progress achieved in the countries, we do see that there is always a population left behind, and particularly men who have sex with men. If you look at the purple, if you see the colors clearly, if you look at the purple lines where you see we have increasing trend everywhere, and even when there are declines everywhere across the populations, like we can see here in Vietnam and in Indonesia, we do not see the decline among men who have sex with men remains less visible than other populations, which means that we have some issues of inequalities particularly affecting this population, linked to models of service delivery, linked to packages of services, and many other aspects that make it that we are not as effective in addressing infections among this population, particularly the young cohorts or the young age groups of men who have sex with men, and we are seeing data supporting this across a number of countries. If we zoom in and look more specifically in detail, and we picked up here as an example, this is highlighted in the report, we have a country with an extremely good success story with regard to reducing new infections. Take Cambodia here. Overall new infections decline is 50% since 2010. AIDS-related deaths decline is quite substantial, at almost 40%. And a very good success in achieving treatment coverage, one of the highest we have in the region, which we have been commending and congratulating Cambodia for. And these results are linked to major achievements with regard to specific populations, as we can see here. Apologies, I can't see very clearly. Among some populations, particularly female sex workers and others. But at the same time, we are seeing that the new infections are increasing among a number of other populations. And that's an absolute perfect reflection of some elements of inequalities that are visible here. Particularly, and we fully understand that when you have an epidemic, you focus mostly on where the infections are happening. But over time, things evolve. You achieve results among some populations, and some others remain left behind, facing an increase of infections. If we can see, like, for example, transgender infections among transgender have increased by 200%. And among male sex workers have increased by 123%. It just highlights that when we look at addressing epidemics in countries, it's really important to look at subcategories of the population to understand who is left behind and remove the inequalities so that we can achieve even progress and ensure that the epidemic does not remains under control. There is rollouts of effective strategies. We know we've been hearing lots about PrEP. There is some good movements, and we see some policies being made for national rollouts of PrEP. There are pilots that are ongoing for 2, 3, 4 years. There are implementation strategies for PrEP. But our observation is if we exclude New Zealand, for example, and Australia, with relatively high numbers of people on PrEP, in almost all countries we do not have the relevant scale or the needed scale that would achieve impact. A lot of efforts are yet to be done. We know, we have seen that there are some policies being adopted for national rollouts and major scale-up of PrEP for implementation and all these things, but we are still at an extremely low coverage level for PrEP, which we know is an extremely effective intervention, particularly for men who have sex with men, but also for the other key populations. We have seen how men who have sex with men remain extremely vulnerable to HIV infections. Same, we have some data here with regard to people who inject drugs, needle syringe programs, as well as opioid substitution therapy. Interestingly, we see that while it is rolled out in many countries, the coverage level is extremely low, which means that we cannot achieve a national or a population level impact with those levels of interventions when the average needle coverage, needle and syringe coverage is much, much lower than the expected 200 target, or when the OST coverage is much lower than the expected 40%. We have very few exceptions that are above those targets, and we know that these countries have achieved tremendous impact on that specific population. Otherwise, we have investments done, but not at the scale that would show us a visible impact on that population, which is the main issue. It's initiatives being taken, being implemented, but not at scale so that we have, we can see the results. Yes, the main challenge is regarded to policy and legal environment. And we know that the strategy, the global aid strategy, clearly highlights a very strong link between the programmatic 95, 95, 95, 95 targets and the other enablers represented by the 10, 10, 10. You cannot achieve the programmatic targets when you have criminalization, high levels of stigma and discrimination, high level of gender-based violence, policies that are not adapted or discriminatory or not allowing people at risk to access services, particularly young populations. This is a snapshot of key aspects, key indicators related to criminalization limiting or restricting different aspects of access to services, and unfortunately is still extremely high. This is particularly important in the context of our region, where the epidemic is mostly among key populations and their partners, who are mostly criminalized almost everywhere. And the other aspects to that, beyond the criminalization-related factors, there are also high levels of stigma and discrimination and other issues, as we can see from some studies recently implemented in a number of countries, how these stigma and discrimination particularly is limiting specific populations from accessing services. In many ways, people are denied access to services, or just they don't feel comfortable to go and ask because of the known and felt and expected levels of stigma and discrimination. And this is really important that to address if we want to move in achieving the programmatic targets. An important element that this report has highlighted globally, and we all know that this is a major focus, particularly for countries in Africa. But when we look at the analysis that has been done, particularly for our Asia and the Pacific, although the numbers are relatively small, and we say that this is mostly a concentrated epidemic focusing on key populations, it really highlights some major issues that we need to urgently focus on and address. So the treatment coverage, particularly for PMTCT, or the services for preventing mother-to-child transmission, are much, much lower. There are major gaps. It is clearly, despite the achievements we have in this region with a number of countries with sizable epidemics like Thailand and Malaysia having achieved elimination of mother-to-child transmission. But even with that, we still have a regional aggregate of less than 50% treatment coverage for pregnant women who are living with HIV, which at the end, through the cascade, leads to a 25% transmission rate, which is extremely high for a region with the capacity is known for its health system. And this leads us to this situation. If we compare the transmission rates between the region, I'm sad to see that Asia and the Pacific has the second highest across all the regions. We keep saying, we see this is probably not a big priority, it's not a big challenge, a big issue for for this region, but the evidence tells us that we are the least performing. And sadly, that's why we are seeing a high number of infections among children, as you can see, during, at 6 weeks after birth and even after the breastfeeding period, leading to about 25%, which is extremely high. But more importantly, sadly, the reported number we started with earlier of about 7,400 children deaths per year, which is extremely high, and this can be avoidable. And this reflects the need to look at the different issues. It has the combination of all what we have said in the past: gender-based violence, social norm affecting gender balance in accessing health services, the lack of focus on this population, and also the adaptation of service deliveries, high levels of stigma and discrimination against key populations, but also against PLHIV. This is leading us to this situation. And all those forms of inequalities are affecting the results as we are seeing, and this absolutely needs to be urgently addressed. The last point that this report highlights, which we would like to look at, is about the need for mobilizing resources to end AIDS. We know that we are facing still a major investment gap if we want to achieve the targets for the AIDS, the response target for our region. There is a major gap. And this is particularly important as we see that the external resources who are specifically funding prevention are in a declining trend. Yes, we have most of the response, as we can see from this graph, specifically coming from domestic sources, but the resources that we have right now are not enough, and there is need to look at various ways for mobilizing resources, but also different forms of accessing resources through social health insurance or domestic resources from central government to low-level governments, and all these various ways of ensuring that the HIV response has the resources it needs to achieve the impact. And then when we look more closely at the data that we have, there is a challenge with regard to where the investments are going and the ability to achieve impacts with the investments made. As you can see, this graph at this moment, you can see the proportion of key populations out of total new HIV infections. At around 72%, the average we mentioned earlier in the beginning, 72% among key populations only. When you add the partner, we come up to 96%. So this is analyzing out of the key populations only infections, as you can see in this slide. So around 72%, 78, 93 for the Philippines, mostly men who have sex with men. But then we compare that with the proportion of HIV prevention spending out of the total HIV expenditure, and you can see how small is that prevention spending. It's much lower. You can compare where the blue level versus the red level. When you have 72% of your infections coming from key populations and less than half or even 16 or 8% in Indonesia of the investments are going to prevention, you will not be able to control the epidemic. You will just be chasing on finding cases and putting them on treatments, and that's absolutely not effective. But then within that, we analyzed also more specifically where we are with regard to key population specific spending within the prevention spending. And normally this should appear as I click on the slide. Here we are. That's with the circles, and you can see that on almost everywhere it's relatively lower than the blue limit, the blue bar, which means that even regardless of how big or small the prevention spending, the spending on key populations is much lower than that. And this is a reflection of the inequalities of focus of investments and the issues of efficiency of programming and intervention. And this brings me to the last slide. We choose to highlight this evidence and present this data to make link with regard to what the global AIDS strategy is telling us. First is that we need to reduce inequalities and look at the sources of what prevents people from accessing the services and why we are not able to achieve the 95, 95, 95, 95 prevention, testing, and treatment targets, which are set up in the right. But we approach that from the aspect of reducing inequalities, models of service delivery, gender norms, gender violence, stigma and discrimination, and so on, many other factors that are creating those inequalities. But we also are seeing, as we have seen in this data, that we cannot achieve those programmatic targets without achieving the 10-10-10, which are the enablers. You need laws and policies, you need decriminalization, you need reduced gender-based violence, and you need all the enablers put in place so that we can achieve as well the programmatic targets. The 10-10-10 and the 95-95-95 go together if you want to achieve the ending of AIDS. And we can only do it when we address it from the perspective of addressing inequalities and putting communities at risk at the center of our consideration for designing. And this links up to our main priorities defined for our Asia-Pacific region, collectively in consultation with communities, with partners, with all stakeholders, governments. At the time of developing the strategy, we collectively agreed that the translation of the global AIDS strategy in all its principles, including focus on communities, programs, and all these things, would be more effective if it is specifically translated on 4 strategic priorities to address for AP. First is the focus on key populations, as we have seen, with the data on who is most affected, and this needs to be looked at in every aspect of our response. Second is modernizing service delivery, and that modernized service delivery means the adaptation of ways and package of models, but as well as packages of service delivery to respond to those inequalities and address them and make the services accessible. But it also brings community-led service delivery, which is extremely important as a key element to be more effective. And then eliminates the barriers for equitable program coverage. All the policy work, all the stigma, discrimination, legal, programmatic policy, related policies, as well as the key focus on stigma and discrimination remains extremely important because we are seeing the evidence that this remains high. And lastly, the aspects of financing, mobilizing sustainable domestic financing, which is extremely important, but it's not only about mobilizing funding, but it's working out the processes and the systems for accessing these financing so that it can be more effective in its implementation. So thank you for your time, and I look forward to further discussing on all these elements with our esteemed panelists. This is the summary of our World AIDS Day report. It provides updated data in its highlights. Again, all the needed evidence for the theme of this year, which is about EQUALIZE. We need action on equalizing access, or on removing all inequalities and ensuring that we can evolve towards ending AIDS, which is a collective target for this region. Thank you for your attention. Over to you, Cedric.
Thank you so much, Taufik. So we heard so much just a moment ago about who is being left behind. We heard about rising epidemics among men who have sex with men in several countries. We've heard about young people, young key populations, particularly accounting for a quarter of new infections across Asia Pacific. We heard a bit about children who are still being infected at a rate of 25% for the region as a whole. So many glaring gaps, and we want to explore the strategies that are going to get us there, that are going to get services to these people, and that are going to equalize. So I'd first like to introduce our panel. We have His Excellency Leng Muli, who is a senior minister and chair of the National AIDS Authority in Cambodia. And of course, we did hear a little bit about the successes of the Cambodian AIDS response, particularly when it comes to prevention. So we welcome his reflections. We are joined by Jules Kim, Chief Executive Officer of the Scarlet Alliance, a sex worker organization for and by sex workers in Australia. Don Tan Tung, Executive Director of the Lighthouse Social Enterprise Vietnam, a LGBTIQ organization working on advocacy and service provision. And finally, here in person, we have Ms. Catherine Johnson, who is the Law, Policy, Health and Development Advisor from the UNDP Bangkok Regional Hub. And we wanted to structure this conversation around the 4 programmatic priorities that Taufik just outlined. And first, I would like to go to His Excellency Muli to speak a bit about the money, because investments are so fundamental. Every programmatic development initiative that we discuss, we need to think through how it's funded. Your Excellency, a first question about Cambodia's investments in prevention. Could you tell me how Cambodia has gone about this initiative and what has the payoff been?
Good morning, everyone. Thank you, Sandra, for your introduction. First, I would like to congratulate the regional office for the launching of this Asia-Pacific Aid Report. As the regional director, Taufik Bakali, had presented, they are good and they are also challenge result that we need to proceed and to continue to combat. Cambodia is not bad, I can say. It's pretty well in fighting against HIV/AIDS. On the decade of 95, the newest data told us that we are now at 84, 99, and 97. We are successful in the second and the third 95 because we invest much on care treatment. And we understand that the lacking behind because we reached only 84% on 89, on the first 85, because during the last 2 years of COVID trade, we have invested less in prevention, and we are also hampered by the threat of COVID-19 that we cannot continue our prevention program as normally. But in Cambodia, we have our our program based on 3 pillars. First, we call ownership and leadership. Second, we call partnership. And third, we call investment. We believe that the country, especially the government, has to lead. But the government cannot do alone. They have to get involved with our partner, development partner, institutional institution, national institution, international institution like UNAID, UNDP, WHO, civil society, community, key population, etc. And then we have to invest, because even with good leadership, good ownership, and with strong partnership, for example, but if there are no money, there are no investment, I think the program cannot work. So our Prime Minister used to tell us that when you deal with AIDS, HIV/AIDS, you must think about making all part of your body working. That means in the human body, every part must be working, must be moving from the top to the toe. So everyone has to get involved, not just government, not just civil society, everyone. So from the government part, we have set up national program with the operator being provincial administration, district administration, commune administration, and this community at all levels of administration had to work with civil society. This is the way that we have done in the past, and we will continue in the past. To answer your question about investment, we have decided first for 24, 25, 26 to invest from the government national budget 5 million each year. That means so for 3 years, we will invest 15 million. If you compare for the ARV cost, the government pay almost 70%. But for the old program, we have reached around 50% at 2023. So, and also as we understand that we are lacking behind in prevention, so we ask the Global Fund to reprogram the grant, so that, for example, the target of PrEP initially planned for 10,000 users. We propose that in the future it must be more than 10,000, up to the 50,000 PrEP, for example, user, for example. And second, we apply people-centered approach by engaging key population to actively involve in the prevention program. So every time when we meet in our institution, we invite all the key population representatives to sit with us, to talk with us. Like last week, I met with a group of formal entertainment worker, and we hear their concern, their difficulty, and we try to help. So when we apply for the funding request for the next cycle, we will get all the key population and community and civil society, NGO, to get enrolled for the preparation of the funding request. So this is what I can answer to your first question.
Thank you so much. So a strong emphasis on having dedicated HIV budgets, working together with civil society, engaging development partners to put the money where there are weaknesses, and in this case, prevention, key populations, and scaling up on PrEP. So, thank you for that answer. And I wanted to ask further to that, in the context of declining international financing, what avenues can countries in the region explore to integrate prevention services into domestic funding? How can we allocate more national budgets to HIV and particularly prevention programming?
To tell the truth, I cannot say on behalf of other countries, but for Cambodia, we are preparing to draft a national policy to eliminate AIDS in 2025, and for sustainable HIV response from 25 to after 2025, up to 2030, for example. In this case, we will combine first national budget to invest where they are lacking in the global fund grant, for example. For example, for this, for the actual case, they are lacking in prevention. So we will concentrate our effort on prevention, providing more and more responsibility to the key population and NGO and civil society. This first. Cambodia is making the use of the global fund and the national budget to strengthen our country system. When I'm talking about national policy to end AIDS, we are talking about country system. Country system means the way the country had to respond to the HIV threat. That means policy, national policy, national law, regulation, recommendation that must include the voice and the need of the people in need, especially the key affected population. For example, last week, as I said,